So why do we do a physical assessment? It's important because we want to make sure that we understand what's going on with our patient. It provides additional data. It's usually should be done in a head-to-toe systematic fashion. The reason for this is not only so that you can make sure that you don't miss anything, but also for your own learning. I know that when I go in to see a patient and I'm doing a physical, I'm going to start with the head and go right on down to the toes. And I do it the same time, the same way every time. And it helps me not leave anything out. And it helps me remember my findings also. So when you do a physical assessment, it can provide confirmation of diagnosis. Oh yeah, your patient has a bellyache. That's why they came to the hospital. And when I look at their stomach, there's nothing unusual, but when I listen, I don't hear bowel sounds. And when I palpate, they're extremely tender in the right lower quadrant. Different techniques are used to gather objective data about the body. We're going to talk about those in later slides. And remember, this is not something that a normal person does. If you went to like a cocktail party and you got right up close to the person next to you and started peering in their eyes and, touching them and listening to their heart and lungs, they would consider you a weirdo and maybe even call the cops. What you're doing is invading someone's personal space. It requires both tact and sensitivity, and every patient is going to require a little bit different approach. So while you're going to be doing your physical assessment in a systematic way, hopefully the same way every time, your interview technique and your getting to know your patient is going to be different every time, and that's something that we're going to discuss more in lecture on Thursday. There are several things that you can do to prepare your patient for physical assessment. As we mentioned before, you're going to use tact, you're going to use sensitivity, you're going to explain what you're going to do to your patient and explain that this will not be painful. You're just going to be listening to heart and lungs and doing a physical assessment. While you're doing your assessment, you want to explain each procedure in detail to your patient. Make sure that they know what you're doing. If you're in a doctor's office, for example, you're going to have the patient change into a gown and go to the bathroom so they're in a comfortable place when you do your physical assessment. And any questions the patient has, you're going to do your best to answer them directly and honestly, but also remembering that you are there to allay anxiety and remembering what your scope is. So you're not going to be revealing test results or saying anything to the patient that's going to cause them anxiety. That environment is just as important as being good at communicating with your patient. You want to make sure that they don't have visitors, that they are comfortable, that their bladder's empty, that they're in a good place for you to go in and assess them. You're going to make sure that they're in a comfortable place. If you have an examination table, make sure that it's clean. Make sure the patient has a gown and a drape to cover themselves. You're going to bring everything with you to do your assessment so that you're not walking in and out of the room while you're assessing the patient. And especially if you're in a hospital, you want to make sure that the patient's door is shut or their curtain is closed so that you provide them with privacy and dignity. It is extremely important to make sure that your patient's privacy and dignity is protected. In SIM, when you're going to be doing simulated assessments on the simulated patients upstairs in SIM's Medical Center, it's very important every time you close that curtain to protect your patient's privacy. There's a lot of equipment that can be used during a physical examination. You're going to have a temperature, a sphygmomanometer. If you're doing a weight, you need a scale. You're going to be using a flashlight or a pen light to check pupils and to do any, focused skin assessments. You want to make sure you have your stethoscope at all times. If you have any wounds or anything that needs measuring, you're going to need some sort of measuring device. If you're checking vision, you're going to need an eye chart. Checking hearing and vibration sense requires a tuning fork. And the otoscope and ophthalmoscope are both things that you should understand. Those are typically used during focused assessments, but you may need to look in your patient's eyes or ears at some point. So make sure that you understand what these devices are and how to use them. Which position is used in physical examination to assess the rectum of a patient? And your choices are supine, Sims, prone, and dorsal recumbent. There are many different positions that you can use during a physical assessment. As you can see in the middle of this list, the Sims position, where a patient is lying on their side with one leg over the other, is used for assessment of the rectum or vagina. All of these positions are important for you to know, and you can go to page 504 to 506 of your trees book and see them, and please know them. This is just a little picture with some of those different positions. As you can see, the Sims is in the upper right-hand corner where the patient is lying on their side, so you do have a good way to assess the patient's backside. And if you look at those different positions, you want to make sure that you understand what the names are for each of them, so that when the doctor says, "Help me get this patient into the prone position," you know that you're going to be flipping the patient over on their stomach and they're going to be lying face down. Vital signs. There's a lovely video on Kaplan. If you go to your first screen of Kaplan in the lower left-hand corner, you're going to watch the video called Obtaining Vital Signs, and that is a thorough example of how you obtain vital signs. Please know the normal ranges for vital signs for healthy adults. Temperature should be around 98.6, pulse rate 60 to 100 beats per minute, respirations are 12 to 20 breaths per minute, blood pressure should be a systolic value of 120 over a diastolic value of 80, and oxygen saturation should be greater than 95%. When you're documenting these vital signs, make sure that if the patient is on oxygen, that your oxygen saturation value tells me they're 95% on room air, RA, which is just regular breathing, no oxygen at all. If they're on 2 liters nasal cannula oxygen, you want to document 95%, 2 liters nasal cannula. So for me, that oxygen saturation value always has 2 parts: the value that your patient is satting at, and then what they are on for oxygen. Room air if they're not on anything. Please know your ranges for healthy adults for vital signs. When do you measure vital signs? So many times. Home health nurses can measure their patients' vital signs when they go for visits. Patients that are admitted always get a set of vitals as soon as they come in. When patients receiving medications that affect their cardiac status, usually for patients that need heart medications, you're going to do an apical pulse. You're going to actually put the stethoscope on the chest and listen for 1 full minute to get your cardiac heart rate for those patients getting cardiac medications. Whenever you're in an emergency situation, you're going to make sure you check your patient's vital signs. That's usually the first thing I do if I'm worried a patient is in trouble, and before and after any invasive diagnostic or surgical procedures. And we are going to actually have a blood pressure clinic sometime this fall where you're going to be acting as the healthcare provider, doing blood pressures out in the community and here on campus. Well, how often do you check the vital signs on your patient? This is very variable. Working in the hospital, it's usually going to depend on the patient's level of acuity, how sick they are. For patients in the ICU, they get vitals at a minimum every hour, and I've taken vitals on my patient every 2 or 5 minutes, depending on what's going on with them and how sick they are. And there are usually doctor's orders that tell you how often you're going to check vital signs on your patient. So a patient with a fever, there are several different types of fevers. I'm not going to read these to you, but please take some time to review them in your book and make sure that you understand the difference between an intermittent and a relapsing or recurrent fever. Many different types of thermometers are used to assess body temperature in hospitalized patients. These are different examples. So in the upper left-hand corner, we have a regular thermometer that can use either an oral probe, which is the blue one, or a rectal probe, which is the red one. Make sure that you understand which probe is on your thermometer before you take your patient's temperature. You do not want to use the rectal probe to take an oral temp, and the values are slightly different for oral versus rectal temperatures. On the right-hand upper right, you see a patient tympanic thermometer. So these also have little safety covers. So you can see in A and B, those little plastic things in the bottom, those are safety covers that you will change out every time you take a temperature. The bottom left is a little plastic strip that goes over the forehead and can measure temperature. And you can see a patient in the lower right, a child being having a temporal thermometer taken. So this temporal probe just goes over the forehead and behind the ear and takes the patient's temperature that way. In this time of COVID, a lot of facilities are using infrared scanners where you don't have to touch your patient at all, which is good for infection control. What are normal temperatures for healthy adults? 98.6 oral, 99.5, a little higher for a rectal temp. Axillary is a little bit lower, 97.7. The tympanic is a little bit higher at 99.5, and forehead temps tend to run a little bit on the lower side, 94. Throughout this lecture, we're going to be talking about age-related differences in many things, in vital signs, in physical assessment, and this information is important for you to realize because, like as in this example of temperature, if you have a 2-year-old who's got a temperature of 99.8, you might be concerned that that might be a fever, but for the 1 to 3-year-old, they're going to run a little bit higher. And, in the same vein, if you have an elderly adult who's maybe age 75 and you take their temperature and it's 97 orally, you're going to know that that's normal for someone who's elderly because they tend to run a little bit lower temperature at baseline. Baseline is a really important thing for you to think about when you're doing physical assessment because you're going to be in a setting, hopefully, where you have a little bit of information on your patient. So if you take your patient's blood pressure and you realize it's 148/57, you can look back in your electronic health record or in your patient's chart and see whether or not that's normal for them or whether that's far outside what they normally read when you take their blood pressure. And as a nurse, a lot of what you're going to be doing is evaluating information using your critical thinking skills and determining, is that something that I need to notify the provider? Is it something I need to keep an eye on and recheck? Or is that baseline for my patient? There's normal, which is 120/80 for blood pressure, but then this baseline reading could be where your patient normally lives. When talking about temperature, there are different things that cause heat in the body. The primary source is metabolism. Muscle movements, hormones, and exercise increase metabolism and therefore increase heat production in the body. Different chemicals, epinephrine and norepinephrine, are released by the adrenal glands when additional heat is required, and that also alters metabolism. Thyroid hormone and shivering also increase heat production. One of the things that your body does when you get very cold is to initiate shivering, which is movements of your muscles, involuntary, and that increases, hopefully, the heat production in your body. And energy production decreases and heat production increases when your body gets cold. There are many sources of heat loss. Your skin is the primary source of heat loss. It's the largest organ in the body, and evaporation of sweat causes cooling in your body. That's why when you run, you get all sweaty, and hopefully that sweat evaporates and your body stays cool. When you breathe in and out, that also is a source of heat loss. Your air inspiration and expiration, you warm and humidify that air when you breathe it in, and when you breathe it out, that's a source of heat loss for your body. And also, peeing and going poop, you're eliminating that urine and feces and also losing heat in that fashion. The methods of transfer of body heat to the external environment are things that you should know and understand as a nurse. They are radiation, convection, evaporation, and conduction. And this little puppy in our slide is an excellent example of conduction, as he is laying on that ice and the ice is transferring the cold to his body, and it's hopefully going to cool him off. He actually looks kind of comfy, pretending this is like a hot summer day. This is another slide explaining the mechanisms of heat exchange. Evaporation of water from body surfaces or breathing passages cools the body. So when you sweat and that sweat comes off your body, that's one way of evaporative cooling. Radiation happens when you are outside in the cold, and the cold air kind of pulls the heat from your body. Convection is that patient who wants a fan running. So the fan is going to be blowing over the body surface and cooling it off. And conduction, like we saw with our little pup in the previous slide, is the direct transfer of heat when objects of different temperatures come into contact. Please review these in your book and make sure that you understand radiation, evaporation, convection, and conduction. So what's the term for the heat that's lost when a person goes out in the cold without a hat? And if you look at your 4 different methods, the only correct answer is B, radiation. There are many factors affecting body temperature. We previously talked about age-related changes with regards to temperature. There is also circadian rhythms. Patients typically have a higher temperature late in the afternoon and a lower temperature when they get up in the morning after they've been asleep at night. If I go out and run 5 miles, I guarantee you my temperature is going to be more elevated than it is now just sitting down. What your state of health is, this is probably the most important reason why we take the temperature of our clients, is to make sure that they are not febrile, because that's your primary indicator that there's an infection going on. And also your environmental temperature. This poor person in the picture looks like they are freezing because it's cold outside and all they have is a blanket to keep them warm. Patients that come in after car accidents or exposure to the elements, one of the most important things that the nurse can do is to keep checking their temperature and use whatever methods are available to you to warm them up. We talked a little bit about equipment used for assessing temperature. Here we have an oral thermometer in the picture. It is a digital thermometer. There are tympanic thermometers that use the ear membrane. There are disposable single-use thermometers, temporal artery thermometers, and automated monitoring devices, such as those that may be found in a hospital unit. A lot of times in the ICU, we'll place a Foley catheter in a patient that has a temperature device already embedded in the catheter, so you're getting a core temperature and it just plugs into the monitor and you can see the patient's temperature in real time. There are also esophageal probes that you can put down a patient's throat. Again, these are often used in critical care environments. These patients typically have breathing tubes in as well, but just know that there are automated monitoring devices that can register a patient's core temperature in real time. Moving on to pulse, the physiology of the pulse is regulated by the autonomic nervous system through the cardiac sinoatrial node. As you can see over here, there's your SA node. This is the basis for the electrical activity of the heart, and it's affected by both the parasympathetic and the sympathetic nervous system. When you think about these two these two parts of your nervous system, you want to remember that parasympathetic stimulation decreases the heart rate. This is, when you take some deep breaths, when you use a little creative visualization, when you can sit down and calm yourself, that's going to decrease your heart rate. Sympathetic stimulation, like what occurs when you see a bear in the woods and realize you have to run away, that's going to increase your heart rate. Usually it's related to the release of norepinephrine and epinephrine. And your pulse rate is measured by counting the number of contractions over a peripheral artery. So I'm going to put my fingers on my patient's radial artery and I'm going to count the number of contractions over a minute, and that's going to give me my rate of pulse in beats per minute. Okay, knowledge check question. Tell whether the following statement is true or false. The normal pulse rate for adolescents and adults ranges from 60 to 100 beats per minute. Is it true or false? Well, it's true. 60 to 100 is your normal pulse rate. So the characteristics of the peripheral pulse are things that you as the nurse are going to have to know. What normal rate is, 60 to 100. What constitutes a fast heart rate, tachycardia, greater than 100 beats per minute. And what's bradycardia, slow, less than 60 beats per minute. All of these vocabulary words are things that you are going to have to know. So if you, for a good study guide, what you might want to do is when you're going through your reading and you're going through your slides here, write down those words that are not familiar to you and make flashcards and study them, because it's not unusual for you to get a test that says tachycardia and you're expected to know that that means a heart rate over 100. That's a fast heart rate. Bradycardia is going to be a slow heart rate. So all these words that are new to you, please write them down and make sure you know them so that you're prepared for those test questions. What's the amplitude and quality of the peripheral pulse? Is it difficult for me to feel that patient's radial artery on the wrist, or is it something that I can see and feel just by barely putting my finger on them? Is it strong? Is it weak? Is it thready? What's the rhythm? Is it normal? Looked up, looked up, looked up, looked up. Or does it sound like they're doing a tap dance? Looked up, looked up, looked up, looked up, looked up. And you're going to get to know what's a normal peripheral pulse and what's abnormal. Practice with yourself. It's really easy for me to check my radial pulse, to check my pedal pulse, to find my dorsalis pedis artery in the middle of my foot, to check behind my ankle bone on the inside of my foot. Get used to what it feels like when you palpate a peripheral pulse and what that should feel like. It's mostly anatomy based, so when you find the radial pulse on yourself, you'll be able to find it on your patient. And don't be surprised, you may have a patient that you can't palpate their radial pulse. I've had several patients who've had surgery and have had their radial artery either sacrificed, taken out because they had an injury, or that they had some sort of vascular surgery where the radial artery was used somewhere else. It's unusual, but it does happen. So get to know your assessments and get to trust them. The stroke volume is the volume of blood ejected with each heartbeat. And when you're talking about pulses, usually they're graded 1 to 2 plus. And if you cannot find a patient's pulse using palpation, you can also use a Doppler device, which is a small handheld ultrasound device. And using some ultrasound gel, you place the probe over the area where you should be able to palpate the artery, and you can hear it using the Doppler machine. A knowledge question: which pulse site is located on the inside of the elbow? And that will be D, your brachial artery. The apical pulse is a measure of cardiac function that the nurse obtains by placing the stethoscope at the apex of the heart and counting for 1 minute. You will hear lub-dub sounds. They represent the heartbeat, and they represent the opening and closing of the valves in the heart. So the apical pulse is a preferred method of calculating the pulse rate in patients who have an irregular heart rhythm. If you're not able to obtain a radial pulse via palpation or before giving medications that affect the cardiac status of the patient. So using your critical thinking skills, you're going to, look at your med list. You're giving your patient digoxin. You know that affects the cardiac status of the patient. Usually these medications have hold parameters. So the physician may have said, digoxin, 0.125 milligrams daily. Please hold for heart rate, for apical pulse rate less than 60. So you as the nurse are going to go assess your patient, take a blood pressure. Using your stethoscope, you'll count the pulse for 1 minute over the apex of the heart, and that will be your apical pulse. And if that rate is less than 60, you're going to hold the digoxin. This is a nice graphic of sites for detecting pulse by light palpation. Again, use this guide and check your pulses on yourself. If you have family members that you live with or close friends, don't hesitate to go and check their pulses. Very important though to remember that carotid pulse, that's the blood supply to the anterior portion of your brain, and the left and the right carotid pulses should always be palpated separately. Never ever should you go in and palpate someone's carotid pulses both at the same time on the left and the right, because you can cause disruption to the blood flow to their brain, and it's just very bad practice. So remember, carotid pulses, one on one side, one on the other side, always separately. Moving on to respiration. Respiration is made up of a couple different things. The first is ventilation, which is the actual movement of air in and out of the lungs. When I breathe in, I'm inhaling. When I breathe out, I'm exhaling. Diffusion is the exchange of oxygen and carbon dioxide. It happens between the alveoli of the lungs and the circulating blood. This is at the cellular level. And then perfusion is the exchange of oxygen and carbon dioxide between circulating blood and tissue cells. So this is the actual blood that is getting out to those cells of the body, oxygenated blood that is going out to the cells of the body, and then the return of blood that is rich in carbon dioxide back to the heart, back to the lungs to be reoxygenated. Another knowledge check question. Please tell whether the following statement is true or false. Changes in the rate and depth of inhalation and exhalation are brought about by the inhibition or stimulation of the respiratory muscles by respiratory centers located in the medulla and the pons. And the answer is true. The pons is the brain stem, and that actually controls your respiratory drive. The rate and depth of breathing are affected by tissue demands. So if I go out on a 5-mile run, I'm absolutely going to have an increase in my rate and depth of breathing as my poor lungs and heart try to keep up with the increased demands of my tissues for oxygenated blood. This is controlled by the respiratory centers in the medulla and the pons, which is why patients who suffer injuries to those areas of the brain are at high risk of death, because that brainstem is what controls your breathing, your heartbeat. It's activated by impulses from chemoreceptors. So the two main chemicals involved in breathing are oxygen and carbon dioxide. And for healthy people without lung disease, without chronic lung disease, an increase in the level of carbon dioxide in your blood is most people's drive to breathe. It's the most powerful respiratory stimulant. So when I go, diving in the ocean and I hold my breath and swim under the sea, when the carbon dioxide in my blood rises, that's going to be the most powerful stimulant for me to pop my head out of the water and take a big deep breath in. Please know these terms. I'm not going to read them all to you, but just understand that these are all terms used to describe respiratory rates. Tachypnea means fast breathing, bradypnea means decreased respiratory rate, and remember your normal respiratory rate is from 12 to 20. So if my patient's breathing 40 times a minute or 44 times a minute, I know that term I'm going to use to describe that will be tachypnea. The respiratory rate is increased. Please know these terms, and again, use your flashcards. Many different factors affect blood pressure. Age, gender, and race all affect patients' blood pressures. Your circadian rhythms, so when I lie down to go to sleep at night, typically that's when I'm at my most relaxed and my blood pressure will drop as I sleep and rest in bed. When I first get up in the morning, I can tell that my blood pressure is rising because, I'm getting out of bed, and then I have a cup of coffee, and that also increases my blood pressure. Don't forget your emotional state. Like this guy in our photo here is clearly angry. I don't want to take his blood pressure. I'm actually afraid to go in the room when my patients look like this. So remember emotional state. If your patient's having terrible pain and you're taking their blood pressure, you're probably going to get an elevated reading. And, unfortunately, drugs and medications absolutely affect blood pressure. The cocaine in the bottom is one of the worst things that you can do for your body, for your health, and for your blood pressure. It's a potent vasoconstrictor, and it definitely increases blood pressure, and it's bad for your blood vessels. The equipment that we use for assessing blood pressure varies depending on your setting. The first photo on the left here is a stethoscope and a sphygmomanometer. That's how you're typically going to assess blood pressure, both in the home setting and at blood pressure clinics. And it's usually considered more accurate to take a manual blood pressure using a sphygmomanometer than the automated blood pressure measurement machine, which is on the far right of this slide, the blue machine that conveniently reads 120/80. This method this is called a Dynamap, and it also reads out on the screen. You can see the yellow is a patient's pulse rate of 63. That's normal. And the patient has an oxygen saturation in the lower left of 99%, and their temperature over here reads 98.1. So this is all normal readings over here. And then this machine in the bottom of your slide is a Doppler ultrasound. That's the device we were talking about earlier. If you can't palpate your patient's pulse, you can use a little ultrasonic gel and take this probe and put the probe up against the patient's where you expect the artery to be, and listen for the pulse, and the sound comes out of the little speaker, and hopefully you hear a nice sound. Where you would normally palpate a pulse, you get to hear it through the Doppler. Assessing blood pressure, definitely use your Kaplan video for this. You're going to experience this in lab, and I want you to take some time to practice at home. You're going to be listening for Korotkov sounds with your stethoscope. The first sound is your systolic blood pressure, and when the sounds stop, that's your diastolic blood pressure. The pulse pressure is a difference between the systolic and diastolic readings. The brachial artery on your upper arm and the popliteal artery behind the knee are most commonly used for blood pressure assessment. And make sure you know your patient's history before you assess blood pressure, especially if your patient has any kind of a surgical history. Patients who have had mastectomies can have lymphedema and lymph swelling on one arm if they've had a mastectomy on one side, and they may even tell you, I can't have my blood pressure taken in this arm because I've had surgery, or I have swelling in this arm. Your dialysis patients may have a fistula in place, and if they have a fistula, you can't take blood pressure on that arm because it could affect the blood flow to the fistula. Taking an orthostatic blood pressure measurement is a specific procedure where you take a consecutive blood pressure and pulse on the same arm 3 times, and it's used to assess for hypertension that happens when the patient stands up. So you're going to make sure that while you're doing this, you're checking the patient for any dizziness, lightheaded, they may become pale or start sweating, and then certainly you're going to want to be aware if they have a history of passing out while this is done, syncope. So you take the blood pressure after your patient has lay in the bed for 3 to 10 minutes, and then you assist them up to sitting on the edge of the bed and wait 3 minutes and take the blood pressure and pulse a second time. And then you're going to assist them to standing and wait a couple minutes, and you're going to make sure that you're assessing them at this time, make sure they're steady on their feet and that they're not having any trouble standing up. After a couple minutes, you're going to take a third time that blood pressure and pulse, and then you're going to record these measurements. So usually in orthostatic, you're going to record it, lying 120/80, sitting 118/55, and standing 105/62. And you'd worry because these are big changes, and the pulse you're going to record as well. So any changes in systolic or diastolic blood pressure, that's something to look out for. So if my blood pressure is normally 120/80 when I'm lying in the bed, and then when I stand up it drops and now I'm 90/50 and I'm dizzy, that's a sign that the patient's having orthostatic difficulties with their blood pressure. Maybe they're dehydrated, maybe they're on the wrong medication, or maybe they have an infection and they're not able to maintain their blood pressure when they stand up. It's important when you're taking a patient's blood pressure to use the correct size of cuff. So the width of the cuff should cover 50% of the limb from the shoulder all the way up, all the way down to the elbow. If it's too narrow, you're going to get too high a reading. If it's too wide, you're going to get too low a reading. And there are cuffs that are made for many patient sizes. I've used PD cuffs on little frail elderly women, and also you will have large adult cuffs for patients who have high body weights or large arms. Make sure you use the correct size of cuff for your patient. So hypertension is another fancy way of saying high blood pressure. Primary and secondary are the two major classifications of hypertension. You will have a whole lecture on hypertension this semester. Just understand that there is, primary hypertension, essential hypertension is really the most common cause of hypertension, and it's just unknown why some people have an increase in their blood pressure. And secondary hypertension is caused by another disease condition. So like if you have an adrenal tumor that's causing you to have elevated blood pressure, it can be caused by renal artery stenosis. It can be caused by kidney disease. There are many other reasons that you could have secondary hypertension, but the most common is primary, otherwise known as essential hypertension. There are many types of antihypertensive medications. These are the major categories. They all work differently to drop blood pressure, and typically patients who have hypertension may be on one or more of these types of medications. It's not uncommon for a patient to be both on a diuretic and a beta blocker. So learn these classes of medications. It's very helpful when you're starting out to learn medications by classes. So diuretics like Lasix or hydrochlorothiazide, they are used to get off water. And one thing as a nurse to remember is that when you're giving your patient a diuretic, they will have to pee. So make sure that they have access to the commode, or that they can walk to the bathroom, or if you're responsible for assisting them to get to the bathroom, that you are ready, because when you give them a diuretic, it's going to make them pee. Beta blockers block sympathetic stimulation and decrease cardiac output, so these will drop your heart rate and also the blood pressure in your patient. Not recommended for patients with respiratory disease. And then calcium channel blockers are another class of antihypertensive medications. They dilate your vessels and relax the smooth muscles and decrease vascular resistance. And then ACE inhibitors are another type of antihypertensive medications. These work by preventing vasoconstriction and they decrease circulatory fluid volume by reducing aldosterone production. And in your fluids and electrolytes lecture, we'll talk a little bit more about the angiotensin-renin-aldosterone system and how it works to maintain the volume of blood in your body, as well as your electrolytes. This is a video demonstration of taking vital signs. You're going to watch that on your own. And this is a lovely video that was made by some nursing students, which talks about physical assessment, stressing the correct areas to listen to the lungs and the heart, and the correct way to assess a belly, and how to interact with your patient and ensure safety after the assessment. Make sure when you go into your patient, the first thing that you're always going to do is verify your patient's ID. You're going to introduce yourself, you're going to smile, you're going to put that patient at ease and let them know that you're there to do an assessment, and make sure you're going to assess the correct patient. Very important to verify your patient's ID, name and date of birth, or name and medical record number, whatever the practice is in your facility. And you're going to practice that every time you interact with a simulated patient in the sim lab. You're going to introduce yourself. Hi, I'm your student nurse. My name's Erica. I'm here to check your vital signs. Can I have your name and your date of birth? All right. Thank you for listening. Okay, here's a final knowledge check question. Which physical assessment technique is used to assess temperature, turgor, texture, moisture, vibration, and shape? And how are you going to check all of these things on your patient? You're not going to be able to assess temperature by looking at them. Percussion will give you some sounds, but it's not appropriate for assessing temperature or texture. Palpation is the correct answer because you're going to touch your patient. This is something that's hard for a lot of students to get used to, but you really are, when you're assessing patients, when you're taking care of them, you're getting right up in their personal space. So it's very important to realize this is not normal for most people, and to try your best to get comfortable with it, not only for yourself, but for your patient. Because the more comfortable you are assessing your patient, the more likely they are to be honest with you and to tell you, oh yeah, I'm having this pain, it's in my right lower quadrant of my abdomen, can you check it out for me? Patients are typically very trusting of their healthcare providers, so it's important for you to use your assessment skills in a sensitive and tactful way to help your patients become comfortable with that. These are the different techniques used during a physical assessment. Inspection is looking with your eyes. Palpation is touching with your hands. Percussion assesses the location, shape, size, and density of tissues. It's a tapping. When you use your fingers to tap against a patient's belly, that's percussion. You can use it to assess lungs, to assess patient's liver. It's something that requires some skill and a lot of practice. Auscultation is when you listen using your stethoscope to assess sound. And olfaction, believe it or not, I've had patients where I have walked in the room and taken a couple sniffs and realized that, oh, something here is very wrong. I'm sure those of you that have had babies understand what I'm talking about when you smell something's not right with a baby. But nurses that have experience have it smelled a lot of things, and you don't forget when you smell something that's gone very wrong. So inspection is the purpose of performing deliberate, purposeful observation in a systematic manner. So if you were to look at this belly on the screen, I would say not normal. That belly has some pretty serious vasculature going on the outside. It looks terribly swollen. This patient, I wouldn't be surprised if they have, some liver disease. They look like they might be a little bit yellow, a little bit jaundiced, and that abdomen, to me, just on inspection, doesn't look normal. How do you palpate someone, you touch them in a therapeutic manner. You're going to make sure you wash your hands every time you walk in a patient's room. Every single time you go in or out of a patient's room in any facility, wash your hands. It is the number one thing that you can do to prevent spread of disease. You're going to use gloves. You're going to use the palm of the hand to assess texture and vibration, and you can use the dorsum or the back of the hand to assess temperature, placing your back of your hand against the patient's cheek or forehead. That's the most accurate way to measure temperature. Using palpation, you can detect a lot of different things about your patient, the shape and size, consistency. You're going to assess a patient's surface of the skin. Even just shaking someone's hands can tell me a lot about them. Are they sweaty? Are they nervous? Are they cold and clammy? Do they feel warm? Do they have good mobility of their limbs? So palpation is something that you're going to use as an important technique for assessment. Light palpation determines tenderness of organs and surrounding tissues, and this is approximately 1/2 inch. Deep palpation is used to evaluate the size of organs, and that's when you're pressing about 1 to 2 inches. I do not recommend this unless you're in a specialty area and you have a lot of experience. You are not going to be hooking a patient's liver. You're not going to be assessing for splenomegaly or hepatomegaly. You're going to use light palpation when you palpate, and most often you're going to palpate the patient's stomach, just to check and make sure there's no masses, that the belly is tender, that they're not having any pain with palpation. It's also used to palpate the posterior thorax excursion. So if I place my hands like the person in this picture in A, has their hands on the patient's lower back, like over the kidneys, over the lungs, and you're going to have them breathe in, and your hands should move up. So they breathe in and they breathe out, and you palpate the excursion of the thorax. You can see how the hands are about 2 inches apart over here in A, and as they breathe in and those lungs expand, the fingers are probably closer to 3 or 4 inches apart over here. So the posterior of the thorax inflates when the patient breathes in and your hands move apart. Percussion. Oh my gosh, this is Keith Moon from The Who, my favorite drummer. Just kidding. Percussion. What is percussion? It's the act of striking one object against another to produce sound, to percuss the abdomen. Sounds have varied qualities. When you place your finger against the patient's belly and you strike that first finger with your other hand, you have varying qualities. And I don't know if you can hear me. I'm percussing the muscle in my leg. It's boring. There's not a lot going on. It's kind of dullness because the area is dense. If I were to percuss my lungs, I don't know if you can hear that, but it's definitely air filled, so it's a little more resonant. If I palpate over my sternum, that's pretty flat. That's a bone. And if I could adjust myself and palpate over my stomach, can't really hear it, but it's a little bit hollow, a little bit different sounding. So when you're looking at percussion, it's really something that takes a lot of practice. It's more of an advanced assessment skill. Absolutely practice it at home. There's probably a lot of YouTube videos out there that can help you develop good percussion skills. Auscultation is probably the most important skill that you're going to develop as a nurse. It's the act of listening using your stethoscope to the sounds of the body. You're going to listen pretty much over all of your patient's organs. You're going to listen to lungs, you're going to listen to heart, you're going to listen to belly, you're going to listen using the bell of the stethoscope over vascular areas to detect bruits, and you use the diaphragm, which is the larger, flatter area, to detect high frequency sounds like breath sounds and blood pressure. Get to know your stethoscope and get comfortable switching the diaphragm to the bell and back again. If you have a Littmann stethoscope, you might have a tunable diaphragm, which reacts to pressure against the scope. More pressure will act like a diaphragm, less pressure will act like a bell. So get to know your stethoscope and practice, practice, practice. What are the characteristics of sound that you hear when you use auscultation? We talk about pitch, which is sound that ranges from high to low, loudness ranging from soft to loud. You will have ease hearing breath sounds because they are typically pretty loud, and you will have difficulty hearing heart sounds because they are typically quite soft, especially when compared with the lung sounds you'll hear. What kind of quality do they have? So sounds of the abdomen, bowel sounds, are often described as musical or tinkling. And what is the duration of those sounds? Is it short, medium, or long? When you walk in to meet your patient for the first time, the first impression that you get is going to be the general survey. You're going to look at your patient's general appearance. Both of these patients in these pictures look well. They have expressions of relative ease on their faces. I don't see a furrowed brow or a grimace on either one of them. They look bright and awake. They're both making good eye contact with the person caring for them. You're going to look at their grooming. They both look like they're well groomed, like they've taken care of themselves. You're going to be able to assess to your licensed assistive personnel your vital signs. You may, send your PCT in the room to get a set of vital signs before you go meet them, but that's part of your general survey. And you're also going to use height, weight, and waist circumference, and you're going to calculate the patient's BMI. That's also part of your general survey. Are they obese? Are they too thin for their age? And remember that BMI may not be accurate for some body types like athletes or patients with large bones or large frames, but the BMI is a good idea of how over or underweight your patient is. We talked already about how to do a head-to-toe physical assessment the same time every way. I'm just going to go through the different systems here. That's how I always do my assessment. I start by introducing myself, and I immediately assess my patient's orientation and do a quick neuro exam. I work in the neuro ICU as as another job once in a while, and I think it's just ingrained in me that I want to get that neuro out of the way. I want to make sure they're awake, they're alert, they're oriented, they're conversant, make sure that there's no deficits, and then I can get on with the rest of my assessments. So going from head to toe, you start with your neuro, head, eyes, ears, nose, and throat, HEENT. Then you go to the cardiovascular system, listen to heart, respiratory system, listen to lungs. Belly, I'm going to listen to my bowel sounds, and I'm going to palpate after listening. Remember that order of operations is different for the belly. Genitourinary, this varies by your assessment location. So for the most part, you will be doing a visual assessment of the GU system on your patients. Unless you're in a specialty area like maternity, which is second semester, or if you work in women's health or men's health or urology, you're going to be doing, a skin assessment. Make sure that there are no lesions or rashes or anything unusual going on, but we're not going to be doing internal GU assessments, just so you know. And for your practice assessments, I do not want you doing GU assessments on your friends and family. I mean, that's up to you depending on how, your husband maybe, your wife maybe, but that's your own personal business. For this purpose of this assignment, I want you to take some time, get really good at listening, heart, lungs, belly, checking their neurologic assessment, checking your musculoskeletal strength, and checking their skin, but go easy on the GU. And then psychosocial assessment. For some patients, this will be the most important part of your assessment because you're going to be assessing, do they have any bad habits, or I don't mean to sound judgmental, but it's really important that you assess your patients for drug, alcohol, tobacco, and marijuana use, because those things can significantly affect health. I know a lot of what we see in the hospital, we go to Wesson 4 for clinical in the spring. I take students there for clinical in the spring, and a lot of what we see is sequelae of drug and alcohol abuse. Liver failure, patients with terrible lungs due to smoking and COPD, patients who have, sequelae of intravenous drug use, infections, A lot of what you see in acute care is due to psychosocial factors. And we know as a fact that a patient's socioeconomic status and their psychosocial resources affect health. Patients that have, live in a certain zip code can have a 10 to 15 year difference in their lifespan simply because of the lack of resources and the increase in psychosocial issues. So this is something as a nurse that you want to be acutely aware of when you do your assessment. And you need to do it in a sensitive and non-judgmental way as well. You're interested in the patient's health and how to have them be as healthy as possible. This is a nice example of a 5-minute nursing assessment. The person in the assessment does a good job with detail. They wash their hands, they ID their patient, they assess for pain, they use all their techniques. And in the abdominal exam, remember, you're going to look first, then listen, then percuss and palpation. The order for the abdominal exam is going to be different because percussion and palpation may affect bowel sounds. So you're going to listen to that belly first. Everything else, you look, touch, percuss, listen, except for the belly exam. Preparation for assessment, you're going to wash your hands, you're going to introduce yourself, you're going to do your general survey, check out your patient, ask them how they're doing, ask if they're having any pain, get their vital signs. Don't forget to smile. You're trying to put these patients at ease. So initially when I walk into my patient's room, I introduce myself. Hi, my name is Erica. I'm going to be your student nurse today from STCC. I'm here to do a physical assessment. Can you please tell me your name and your date of birth? I know immediately. They know who they are. That's my person assessment. Then I move on. I say, can you tell me where we are today? Hopefully the patient says, we're at Bay State Medical Center, or we're at Hartford Hospital, or we're in the neuro ICU, and they know where they are. And then I ask them, can you please tell me what day it is today? Oh, it's Saturday, or it's Sunday, or it's, September 24th, 2000, or it's, a week before Christmas, or, whatever you use for time orientation. Usually if a person can't tell me the actual date or the day of the week, then I go out and I ask them if they can tell me what month it is. Sometimes patients, can't keep track of the day when they're in the hospital, but if they can tell me the right month and the year, then I'm usually pretty happy. In most hospital rooms, there will be a sign or a calendar up on the wall, so the patient will be able to look up and check the date. Just be wary of this because some patients with dementia may know that they are not accurate when it comes to date or time, and they might, look up on the board and say, oh, today is September 20th, 2000. And you can, just ask them, did you read that off the board? Do you know that that's the date today? And, do a little further assessment if they're off by their date or their time. I ask them to smile big for me and check for any sort of facial droop. I ask them to hold their arms out like they're holding a pizza and close their eyes. And if one limb falls on one side or the other, that's considered a drift. And that's concerning for a neurologic injury or weakness. If their speech is clear, that makes me happy because slurred speech is also a sign of a neurologic defect or deficit. Using your pen light, you're going to check their pupillary response. Make sure that it's equal and brisk. Both pupils should restrict when either pupil is stimulated by the light. And you're going to, if you're assessing a full neurologic assessment, you're going to ask about their sense of smell. Can you smell this cup of coffee by your bedside? If you have chocolate, you can, ask them to close their eyes and identify the smell. Very infrequently have I ever assessed cranial nerve 1. Usually it's for patients who have like pituitary surgery, who the surgeon's concerned about injury to that first cranial nerve. And actually in the advent of coronavirus, apparently loss of sense of smell is a symptom of corona, so we may be assessing sense of smell more often now. I have them push and pull against my arms to check their motor strength against resistance. Motor strength is graded from 1 to 5, with 5 being the strongest, and that means they can push against me. Not only can they push against gravity, but they can also push against my resistance. I may write a number in their palm and see if they can recognize what number I'm writing. That's called graphesthesia. And I can put my pen in their hand and ask if they can identify the item with their eyes closed. That's stereognosis. Using the edge of a pen or the end of my stethoscope, I can check for a plantar reflex or a Babinski, running the pen up the outside of the patient's foot. And then you're going to look at your Trees and Wilkinson book for a detailed neurologic cranial nerve assessment. These are just my orientation questions. I like to ask, can you tell me the date today? Can you tell me what day it is? If they don't know those questions, I move on to month and year, and then season and maybe holiday if they need further assistance. For place, usually it's, can you tell me where you are? If they're, know they're in the hospital, that makes me happy. If they can tell me the specific name of the hospital, that's great. If they can tell me what unit of the hospital they're in, then I know that they're completely oriented to place. I ask name and date of birth because those are my two identifying information that I need to know that I'm taking care of the right patient. If there's a visitor in the room, I always ask it, can you tell me who this is? Oh yeah, that's my wife, Susie. Is it okay if I ask you questions while Susie's in the room, or do you want her to step out? For HIPAA, it's really important to remember that you are dealing with protected health information and you don't want to speak about anything in front of the patient's visitor that the patient might not want the visitor to know. Very important. For other situational awareness, I ask, can you tell me what brought you to the hospital? You can also ask, can you tell me who the president is? But that just usually leads to political conversation, so I try to avoid that. If they can tell me why they're here, that's always a good idea of how oriented the person is and how much knowledge they have about their own condition. And that will also set you up for how much teaching you need to do or how much teaching you can do with this patient. I'm always really happy when a patient can tell me exactly what's going on with them, and it helps me be able to teach them to the best of my ability about their, their circumstances and their situation and how they can maintain their best level of health. Moving on, you check for the patency of the nose, you inspect the ears, palpate the ears, see if they're having any pain in their ears. You can test their hearing using a whispered voice. Palpate the external nose and the frontal and maxillary sinuses. You can check and make sure they have patent nares and they have no problems with breathing. And if you want to get very involved in your nose inspection, you can use your otoscope and look into the anterior nares and turbinates, and you can examine the patient's septum. So older adult considerations, patients can have a thin grayish ring around the cornea. That's called arcus cinereus, and this is a good picture. Often in people of color, you'll see it very pronounced. So this patient actually has brown eyes, and that ring around the outside is arcus cinereus. Normal age-related changes can be present. Patients can have decreases in their visual acuity, in their hearing, and in their sense of smell, taste, and touch. And remember, if your patient wears dentures, please ask them to remove them and do a thorough assessment of their mouth for any lesions or wounds under the dentures. Moving on to the pulmonary assessment, you're going to look at your patient and assess the diameter of the anterior to posterior and lateral diameters. And see how the patient looks in general. Do they appear to have a barrel chest, which might be indicative of respiratory symptoms or respiratory disease? Normally, the patient's chest is going to be half as wide from the front to the back as it is from the shoulder to the shoulder. So lateral might be 2 feet and anterior posterior is 1 foot. You're going to palpate the spine and the posterior thorax. You're going to listen to the lungs across and down the posterior thorax to the bases as the patient breathes slowly and deeply, going in a ladder format, like from one side to the other. You're going to inspect the anterior thorax for symmetry and development. Make sure your patient is comfortable when you're doing this and that you ensure their privacy. You're going to palpate the anterior thorax, usually just using the palm of your hands. You can just go down the sides of the chest. Try to avoid palpating breasts in a woman. You're going to do breast exams separately. And you're going to listen anteriorly while the patient breathes slowly and deeply. Make sure that you don't have your patient hyperventilate themselves. Slow, deep breaths, and take your time listening all throughout the thorax. This is the order of auscultation. As you can see, you start in the back and you have a ladder fashion here to here, here to here, here to here, and just kind of go down the whole front, the back of the chest, and then the front of the chest, same thing in a ladder fashion. And especially in patients who are heavier, if you listen on the sides underneath the axilla, you can hear some good breath sounds on the side as well. This is a nice website where you can listen to breath sounds. So please take some time and go to these different websites and listen to what normal, bronchiovesicular, and vesicular sounds sound like and where they're located. In older adults, they may have an increased AP chest diameter. They may have an increase in the dorsal spinal curve, kyphosis, or kind of a hunched back appearance. They may have decreased thoracic expansion just as they age. And then you may find that some elderly adults use their accessory muscles to exhale. Especially patients that have COPD can have pretty marked difference in their ability to exhale. So some changes may be age-related, but some changes may be related to COPD as well. Moving on to the cardiovascular assessment, you're going to use the bell of your stethoscope, again, as previously mentioned, to listen to your carotid arteries. Always assess the carotid separately, not both at the same time. If you didn't already previously look at the patient during the neck assessment, you look for JVD, and the way you do that is you have the patient sit in like a semi-Fowler's position up in the bed, and you just watch to see if those jugular veins are distended. That's a sign of fluid overload, jugular venous distension. You're going to look at the area over the heart for contour, any pulsations or heaves. You try and look for that PMI, the point of maximal impact, at the 4th to 5th intercostal space at the left midclavicular line. Using a closed palm, you can also palpate the precordium for pulsations. And when you listen, you're going to start at the aortic, the 2nd right intercostal space, move on to the pulmonic on the left side of the chest, then down a bit to Erb's point at the 3rd intercostal space at the left sternal border, to the tricuspid point at the 4th intercostal space, left sternal border, and then you're going to move to the right to the midclavicular line and listen at the to the left, the 5th left intercostal space at the midclavicular line for the mitral valve. And a good mnemonic to remember these landmarks is ape to man. Here are the order of auscultation of your heart sounds. In this picture is a nice example. You start here at the aortic location, move to the pulmonic, Erb's point, then to the tricuspid, and then to the mitral. And you're going to remember to always use a systematic approach when you're assessing and try to do the same thing every time. This will help you so that you don't miss out on sounds and so you become practiced at doing your physical assessment. And these are some nice auscultation websites that you can go to and hear what normal heart sounds sound like. You will have much more difficulty hearing heart sounds in general than lung sounds. Lung sounds are much louder and easier to hear. Heart sounds really do require the stethoscope to be in the right place on the patient's chest, and they require a little more listening. They're much softer sounds. There are some cardiovascular and peripheral vascular variations in newborns and children. First of which is you may be able to see the pulsation of the heart through the chest wall if it's thin. They may have sinus dysrhythmia, which means the rate is slightly irregular. It increases with inspiration and decreases with expiration. Some adults also have a sinus dysrhythmia. And S3 may be present in about 1/3 of all children. And S3 is where you, instead of having a lub-dub, 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 you hear the valve opening and closing. So it's lub-dub-dub, lub-dub-dub, lub-dub-dub. It's not that pronounced, and it may be difficult to pick up. I'm not a cardiac specialty nurse, so I have a difficult time discerning the different heart murmurs and the different heart sounds. But if you hear something irregular, just go get your clinical instructor and we can listen to it together and see if we can figure out what's going on. Some patients who are very athletic may have what's called a physiologic split, which is another type of S3, and it's a normal finding, and it happens when patients are very fit. Also remember, young people, your children and newborns will have a more rapid heart rate until about 8 years of age. Vascular variations, cardiovascular variations in older adults. They may have a difficult to palpate apical pulse, especially patients that are a little bit heavier or who have some heart failure. Their PMI may be moved down and to the left. So your patient may not, meet the textbook definition of where their PMI is. So if you're having a difficult time palpating your patient's apical pulse, you may want to try moving your fingers a little bit down and to the left. They may also have difficult to palpate distal arteries or dilated proximal arteries. They may have varicose veins, which are prominent and tortuous, and they may also have increase in both systolic and diastolic blood pressure. When you're doing your gastrointestinal assessment, you want to make sure you assess by looking first, then listening before you touch the patient's stomach. This is really important because if you palpate or percuss the belly, you may disturb the bowel sounds heard by auscultation. So we listen first. Then you're going to inspect the area for any lesions, contour, pulsations. You're going to check the umbilicus, make sure that it's, check if it's an innie or an outie, make sure there's nothing unusual going on. The patients may have hernias. You want to check and see if this is a new finding. You can often ask the patient about scars. I see you have a scar on your abdomen. Have you had surgery in the past? And usually they can tell you. When you listen to the quadrants of the abdomen for bowel sounds, it's important to go in order. So you start at the right lower quadrant, then you move to right upper, left upper, and then left lower. It can take up to 2 minutes to hear sounds, so be patient and wait. I always tell my clinical students, if you're going to write down no bowel sounds, that's a problem. If you cannot auscultate bowel sounds on your patient, make sure you get your clinical instructor, because if they don't have bowel sounds, that's indicative of a problem, and you want to make sure that you do a thorough assessment and take good care of your patient. Who knows, they may have some sort of bowel impaction, or they may have an ileus, and you might be responsible for getting them treatment by doing a thorough assessment. You're going to listen with the bell of the stethoscope over the vascular areas. So you're going to listen over the abdominal aorta. You're going to listen over the femoral arteries and the iliac arteries for bruits. And gently you're going to palpate all 4 quadrants using your critical thinking skills to palpate last if the patient complains of pain. So if your patient says, oh, I have terrible pain, it's in my right upper quadrant, remember, you're going to look first, then use your stethoscope and listen, and then you're going to palpate very gently, and I would go to the right upper quadrant last. And you're going to also palpate and grade the femoral pulses. This is a nice picture of what organs are beneath the abdominal quadrants and where a patient might have pain if they're having a difficulty with an organ. So that patient in the right upper quadrant, they may be having, difficulties with their liver, and that's why they're having pain there. Common variations in the abdominal assessment for children's, newborns, and older adults. Newborns, you'll see their umbilical cord. It dries and falls off within the first few weeks of life. For care, which you will learn in your 2nd semester when you have maternity and newborn, you're just going to clean that gently and it should fall off on its own. Children under 5 years of age, you may actually be able to see peristaltic waves while they digest their food. It's kind of fascinating if you've ever seen this. And they also may have a pot belly. For older adults, they can have decreased abdominal tone, decreased bowel sounds, but not absent. It just may take a longer time to hear them, or they may be fainter than young adults would be. And they also can have accumulation of fat on the abdomen and hips. Now for genitourinary assessment, we had already talked about when you do your assessment on your friends, you're not going to get all up in their personal business. But for your patients, you will make sure that you assess the external genitalia for color, for symmetry, and see if there are any lesions or any discharge. For males, you're going to inspect the external genitalia for contour, color, any swelling or redness and or discharge. If the patient is uncircumcised, you're going to gently retract the foreskin for inspection of the glands. And if your patient is uncircumcised, you will make sure that you pull the foreskin back down where it belongs after you inspect and clean the area. This is very important for patients who are uncircumcised because there can be significant problems with the glands if the patient is uncircumcised and the foreskin is left retracted. So this is something that I always talk about in clinical when you're assessing a male genitalia and your patient's uncircumcised. Make sure that you retract the foreskin for your inspection and for hygienic care, and then make sure the foreskin is replaced where it belongs. You can always do a thorough interview with your patient about the genitourinary system. Are you having any symptoms? Do you have any trouble peeing? Do you have any pain or burning? And any issues with incontinence? Okay, for musculoskeletal inspection, I do a lot of this when I first assess my patient and do their neurologic exam. But you can do a thorough cranial nerve assessment by following these steps, asking them to smile, frown, wrinkle forehead, and puff cheeks. You ask the patient to stick their tongue out, move it to each side. You can palpate the jaw muscles when the patient opens and closes their jaw. You can test the sensation of the face with cotton ball light touch. For cranial nerve 11, you want to ask the patient to shrug shoulders and turn head. And you're going to inspect the upper extremities, palpate for temperature and turgor, and then have patient put the arms out with palms up, then turn palms down and assess their strength. I always ask them to pull up against my hands, push down against my hands, and I repeat that with the lower extremities. For the lower extremities, you're going to check for edema. I usually check my pedal and my ankle pulses, which I'm like drawing a blank on. Posterior tibialis pulses. So your dorsalis pedis pulse is the top of the foot, and your posterior tibialis is right behind that medial malleolus, that ankle bone on the inside. So I always check my pulses, and at the same time, while I'm down around my patient's foot, I'm going to ask them to press into my hands like they're stepping on the brake and the gas at the same time, and then pull up with their toes towards their head. So that way I can assess dorsiflexion flexion and plantar flexion. And I'm also going to assess for edema at the same time. Skin inspection, very important part of any nursing assessment. You're going to check the skin for, good perfusion, make sure that your patients are, their skin is warm and dry, assess for any bleeding or bruising. Are there any open areas or lesions? You're going to check, especially, your younger patients, they may have multiple tattoos, make sure that they're well healed and that they're not, in any way infected or causing any problems. Piercings are important to know also, especially if you're in acute care, because you're going to have to remove those piercings if your patient goes to MRI. You're going to make sure if your patient has any wounds of any kind, they are documented thoroughly, because a patient gets admitted to the hospital and has a wound and it's not documented on admission, and it looks like they got that wound while they were in the hospital, that hospital is going to lose money for that stay. Remember, use the dorsum of the hand to assess temperature. You're going to palpate your patient's skin for texture, for moisture. Turgor is an assessment of the fluid status of your patient, and this is done by gently pinching the skin under the clavicle or the forearm. This should not hurt, and what you're going to look for is the skin goes back to its original shape when you pinch it gently. That will tell you your patient is well hydrated. If your patient has poor turgor, that means that you pinch their skin and it stays kind of tented when you let it go. That's a sign the patient is dehydrated and needs more fluid. You're going to look for edema and swelling. You're going to also look at the patient's nails for texture, condition, capillary refill, and you're going to look at the hair and the scalp for color, texture, and distribution. During the health history, typically a nurse will ask lifestyle and psychosocial questions of the patient. This can be continued or expanded on during the physical assessment. What I typically ask my patients, can you tell me, do you smoke cigarettes? Do you smoke marijuana? Do you use any drugs? Do you drink any alcohol? I am that straightforward with them. And if they say yes to any of those questions, then I make sure to clarify my answers. Oh, you smoke marijuana, how much marijuana do you smoke in a day? Is it medical marijuana? Do you have a prescription? How long have you been doing this? Do you find it helpful? It's really important to clarify your answers, because patients that come into the hospital who drink, for example, so say my patient says I drink 2 bottles of wine a night with dinner, and that's important information for me to know and to document, because if that patient is accustomed to having alcohol every day and they don't get it in the hospital, they're at risk for alcohol withdrawal syndrome, which is treatable, but it's something that we want to be aware of when your patient's being hospitalized. It's important information for the nurse to assess. If my patient has a lot of bruises on them, I will ask them about that. On many admission assessments now, there are questions about domestic abuse. So it may be just a part of your assessment to ask the patient if they feel safe at home, or do they have any concerns for their safety. Of course, you're going to have to use your judgment. If the patient has a hovering or, obviously over-concerned family member, you may want to ask them to step out while you ask this question, because you wouldn't want the patient to be a victim of abuse and to have them, have it made worse by asking them around their abuser. And you can also ask about social support and what available assistance the patient has, especially if you're planning for discharge of a patient who's going to need some help. So if you have a patient who had a broken leg and they have a cast and they're going to need a rolled walker to get around, you would always make sure that they're going home to a safe environment. Do you have stairs? Can you tell me about your house? Where's your bathroom? Do you have stairs to get into your house? And who's there to help you get around, to help you cook meals and to help care for yourself. So these are all questions that are part of an admission assessment, part of a thorough assessment that you're going to want to make sure that you ask your patients. So, you've made it through the flipped lecture on assessment. Your mission at this point is to go out and complete at least 3 assessments on 3 different people over the next week or few days, or however many days you have left before lecture on Thursday. Remember, do not do a genital and rectal exam. These are typically done in specialized areas, and you're going to learn this in lab on a simulated patient. You're going to use your stethoscope to listen to heart, lungs, belly, and auscultate for bruits using the bell. Find and palpate pulses in both wrists and feet, and the femoral arteries are good ones to know as well. You're going to do carotid arteries, but one at a time. If you can, please pick a variety of different ages, shapes, and sizes, because there are big differences in how a person sounds, how a person feels based on their body habitus. Practice, practice, practice auscultation and palpation. You can also practice percussion if you wish. Use your Trees and Wilkinson Chapter 21 procedures as a guide. Your goal is to be comfortable doing a physical assessment on any patient after this lecture and your practice at home. Thank you.